So nice to see you all. Some of you I'm seeing again. I will introduce myself briefly and then I'll show my slides. And if you have seen these slides either from me or from someone else before, that's fine. Just, think through, can you predict what I'm going to say? Can you ask sort of a question that moves the conversation on for everybody else? Um, and even if you've seen these slides and you don't remember them, then that's why I'll show them again. Okay, so I am a professor at UC Berkeley in the Environmental Health Sciences Department and in the Epidemiology Department, and I'm an occupational epidemiologist, which you will know what that means pretty soon, by training. And I study my research is kind of in two branches. One is this very statistical questions and large cohorts of folks who work at General Motors or in textiles or in metal manufacturing, trying to understand whether the chemicals they work with are making them sick and why people leave work and how that kind of messes up this calculation. So it's very the stats are pretty sophisticated in that level of work. And then the other part of work that I do is more community-based participatory research. So we work with unions or we work with county or we work with community advocates to answer more practical current questions in the community. So examples of two things that I've worked on recently are, I guess not that recently anymore, but during COVID, we looked at protections for grocery store workers. Right when COVID hit, you might remember grocery store workers still had to go to work and they had no masks and everyone was putting up those plexiglass everything. And we sort of did a survey on behalf of the union for the folks who work at the grocery stores to try to understand what was happening. And then more recently, looking at wage theft and health and safety issues among restaurant workers in California. So there's very practical questions and these very sophisticated statistical questions. And that's sort of my two areas. So I am going to share some slides. All right, so I'm going to give an introduction to occupational environmental epidemiology, and I'm going to start at the top, which is the word epidemiology, which is sort of a funny word. Pre-COVID, no one knew what that word meant, but now some people do know what the word means, but they associate it mostly with COVID, which makes sense. But what it means is it breaks down epidemos and logos to study what is among the people. And so in this case, we are usually studying health and health-related conditions that are among the people. But that's what epidemiology means. There's no skin anything actually. Like you could study skin diseases, but that's what that word breaks down to mean. The field, this is sort of the formal definition. It is a study of the distribution and determinants of health conditions in human populations. So to break that down, the distribution means who's getting sick with what, like how is disease distributed among the population. And the determinants means why. Why are people getting sick? And the health conditions is really broad. It can be chronic diseases, infectious diseases, injury, mental health, I mean, all sorts of things. And then it's in humans. So I study humans, but the key feature and one of the main distinctions between this field and medicine is it's a population level science. So we're not looking at individuals, like you go to the doctor and the doctor, like I have no clinical training. You would not really want me to be like, what is this thing I have on my hand? I don't know. But we look at in populations, and that could be like, California or New York, or it could be children, or it could be prisoners, or, sort of any group as we define them. What is the distribution? So who's getting sick with what and why in that population? And the key question that we ask these questions with the implicit and underlying question of what can we do to intervene? Like, what can we do to make things better? And so that does sometimes lead to different sorts of questions. So there's two fundamental underlying assumptions in epidemiology. And the first is that human disease does not occur at random. There are causal factors, there are preventive factors. We might not know them all, for sure, but it is not like a roll of the dice. There are things at play that cause and prevent illness. And that's the second one. human diseases, causal and preventive factors. And that doesn't mean we're ever going to know them all, but we can know some of them. So in order to understand, so we need the knowledge of the distribution and frequency of disease. So who's getting it and how often are they getting it in order to describe patterns of disease and in order to formulate hypotheses regarding what the causal and preventive factors are. What are the determinants? What are the risk factors? These are all the words that we use. So if we know how disease or injury or a health condition is spread out in a population, then we can start to think like, could it be this? Could it be that? And we can sort of get to the bottom of it and try to do something about the problem. Epidemiology in general contributes to the rationale for policies and services, but in general, as someone as such as myself is not directly involved in policy or in delivery of services, but more will give information to policymakers that they need to make policy and give information to folks who are running services to run the right kind of service. So I'm going to spend a little time talking about how we can describe big picture health problems. When I talk about big picture health patterns, does anything come to mind? Do you think of like what are things, when you think about the health of a population, what is something that you might think of?
Trends and like symptoms, maybe?
Sure, yeah, symptoms, and symptoms can be anything from whatever the disease is. Yep, that's right.
Age distribution.
Age distribution is a good one. You're definitely going to have to consider that. Yep. There's something that happens to all of us eventually. We often look at mortality statistics, right? Who's dying, how old they are when they die, what they die of, who's dying, where they die. So we look at a lot of death statistics. We look at life expectancy, we look at leading causes of death, and we look at death by location, age, race, ethnicity, sex groups, lots of other things. And partially this is true because in the US and in many countries, death is one of the few things we track, birth and death. Some countries also do a pretty good job tracking who's getting sick from other things. Cancer registries, we do a pretty good job with cancer in this country. Denmark does a great job tracking everything, but some countries do a pretty poor job of tracking everything. But almost every country tracks birth and death. And that actually is a lot of information. If you know, you can figure out sort of a lot from that. And we'll look at some inequalities that happen in various different places, and you can find out a lot. The other thing that is sort of a big picture way of looking at the health of a population is something called DALYs or DALYs. I've heard it pronounced both ways, and I'm not too sure which was the right way, but it's disability adjusted life years. And I'll walk you through some of the instinct behind that. And it can be another way to understand the impact of certain conditions and how that varies in different areas. And there's a couple of disease terms I just want to make sure that we clarify before I move on, because I'm going to use them and not everyone knows what these things mean. So I'll talk about acute disease and chronic disease. I'll talk about incident and prevalent disease. Does anyone know what the difference between acute and a chronic disease is? It's just time. Acute disease happens quickly, and chronic disease goes on for a long time. It has nothing to do with severity. So an acute disease could be a cold, not really that big a deal, but it's over pretty fast. Comes on pretty fast, it's over pretty fast. Or an acute disease could be a fatal heart attack. Comes on fast, it's over fast. A chronic disease could be cancer. It could be Alzheimer's, or it could be, a pretty well-controlled asthma, which actually could be bad. And that has acute moments within it. So you could have chronic, let me think of something else, eczema. I have eczema, which is like a rash if I use the wrong lotion or whatever, I get a rash. That's actually really not that big a deal. I can pretty much control it, but that's a chronic condition. But it's not really gonna have a huge impact on my life, right? But someone who's got Alzheimer's, that's a chronic condition. It's going to have a huge impact on their life. So acute and chronic is just about time and how quickly it happens, and often how quickly it happens in relation to the exposure. So if you hang out with someone who's got COVID, I mean, you might get COVID in a few days, right? It's going to happen pretty quickly. And then most people are not getting super sick from COVID. You get a little sick from COVID. It happens kind of fast. You move on. Some people get long COVID. That's a little bit different. When we're talking about cancers, the exposure that caused anybody's cancer happened 10, 15, or 20 years ago. So if I get diagnosed with cancer today, it does not matter what I was exposed to yesterday or earlier this year. People are going to be looking 10, 20 years in the past to figure out what happened to me then and what was I exposed to then that caused the cancer that I have now. So there's lots of time issues when we talk about diseases and what's causing them and how fast they happen and how we track them. And incident and prevalent also has a time component. Does anyone know what an incident versus prevalent disease is?
Is it like duration?
Yeah, almost, yeah. I mean, yeah. It has to do with whether it's a new onset or whether it's existing in the population. So it kind of has to do with duration. So an incident disease is a new disease. And so if you want to know, like, if you go into a school and you want to know, you think there's like a chemical or something at the school, it's making kids get asthma. You would want to know how many new cases of asthma were occurring in that school. Kids who did not have asthma, but they were exposed to some chemical and now they do have asthma. That's a new incidence of asthma. That might let you know that there's something to remove in the school. It's different than prevalent asthma, which is if you go into a school and you want to know how many inhalers you should keep on hand in case there's a problem, you want to know how many kids already have asthma, right? And that they could have had asthma since they were 2. They could have had asthma they could have gotten it yesterday. It really doesn't matter, but how many people might be asthmatic? And so prevalent is what exists in the population right now. And that can let you know about services and how you're going to manage it. Incident is new onset diseases, and that lets you know like who's tipped over into disease. Daisy.
To understand clearly, how about COVID falling to the category? COVID is right now, or 2019 is named differently, or?
COVID-19. Well, we'll
Mhm.
still calling it mostly COVID-19, but it has different strains. But I think, so right now when they are, you can still find out like how COVID's pretty low right now in the US, which means there's not very many new incident cases. And COVID is an example of a disease that you can get over and over again. I mean, I've had it twice, right? So you have it, you get better, you have it again, you get better, right? And so an incident, COVID would probably be every time someone gets COVID again. So I had it once, I didn't have it for 2 years. I had it again. I've had COVID twice. I've been an incident COVID case twice. And versus prevalent COVID would be like COVID's pretty short. I mean, it doesn't feel short when you have it because it sucks and it lasts 10 days. But frankly, it's pretty short in how as far as diseases go, unless you're talking about long COVID. And actually, let's switch over to long COVID. Long COVID is a situation where people just are getting better. The chaos that's caused in their bodies are making them really sick for months, right? And so then you might look in and be like, how many people are currently suffering from COVID? It's going to be mostly people who have long COVID because everybody else is kind of rotating quickly through. Did that answer your question?
So long COVID will be prevalent, or?
Prevalent, every disease is incident and prevalent at any given point in time.
Okay.
So both are happen. I can get COVID and then I have COVID and then I don't have COVID anymore,
Okay.
right? Or someone can get cancer, have cancer, be treated for cancer, and be cancer free. So every person the disease moves through all of these cycles. As an epidemiologist, if I want to know what's causing a disease, I probably want to collect incident disease, what's new diseases and what caused it. If I want to know if I need to get a whole bunch of inhalers, or if I want to know, am I going into an area where there's a lot of folks who are going to have Alzheimer's and I'm going to have a lot of social services set up to deal with, how do I deal with it? I want to know how much Alzheimer's there is in the community, regardless of how long they've had it. And because then I need to have, social services and homes and support systems and all those things that you need to have. But if I want to know what's causing Alzheimer's, then I want to know how many new cases of Alzheimer's are coming in. And we'll get into that a little bit more as we go on. I want to show some big picture statistics of diseases and how we talk about them and how it helps us sort of understand over time and around the world and locally. And most of these graphs are either global or in the US. But it would be interesting for folks, especially And a few of you are in Korea to look at the Korean statistics as well. So some of my graphs, but not all of them, come from a website called Our World in Data. It's an amazing website. It's free. You just go on. I could waste your whole day digging around Our World in Data, finding totally awesome graphs of anything. Well, not anything, lots of things. Okay, but here is a graph of causes of death around the world. So this is the whole world. And this is the estimated number. So this is a count of deaths. And this is time here on the x-axis. So it goes from 1980 up until fairly recently, a few years ago, 2021. And we have here the number of folks who died from non-communicable diseases, which are called NCDs. And this is basically everything that's not infectious. And on this graph, also not an injury. So cancer, heart disease, respiratory disease, Alzheimer's, kidney disease, it's all down here and non-communicable. It just means you can't catch it from someone. And then in the green is the communicable diseases, but also the maternal, neonatal, and nutritional diseases are here in green. And then the sandy color on top is injuries. And so you can see that there's, maybe 500,000, like in 1980, there's maybe 500,000. No, that would be like 5 million injuries and I don't know what that is, 15 million communicable, maternal, et cetera, and 25 million of the non-communicable diseases. So someone tell me what you see in this graph. What do you notice?
Okay. There's like generally it looks like overall there's an increase, but then there's like a small like spike towards the later, like between 2015 and 2021.
Mm-hmm,
It's like a sort of an increase.
mm-hmm,
But also if we, at least I think, if you look at the communicable stuff, that slowly like on its own has shrunk a little bit compared to
mm-hmm.
like uh non-commu
Communicable.
non-communicable
Yeah. Yeah, that's right. And so what is that spike in? What category does that spike occur in?
communi communicable
Communicable. And what is it? What
COVID.
happened in 2020?
COVID.
COVID.
COVID. Yeah, that's our COVID spike. And it's already evening out. It will even out, but that's right. Things were marching along at sort of some pace, and then boink, all of a sudden there was COVID. And so you can see that there weren't really more deaths here in the non-communicable diseases or in the injuries. It was really a communicable. Well, it could have been any of these, but it was COVID. Okay, and so that's great. So something that you mentioned is that generally this green category was sort of relatively going down compared to the pink category over time. That's true. And you also mentioned that these diseases are going up. So let me take a look at this. I'm gonna show the same graph, but in the US. So, and actually over more time. So this is now from, well, this won't include COVID. So this is a century, so a lot more time. And taking a look here, the purple now is these non-communicable diseases, and then we have communicable, infectious, and neonatal in this orangey brown color, and then what they're calling accidents, they're calling injuries in the last graph here on the top. So again, we see sort of the same pattern, right? There are very, very, very few deaths comparatively at the beginning of the 1900s. And then things are kind of, what else do people see?
What's that spike in 1919, is that?
We
1915?
had a flu. That's a Spanish flu.
Oh,
I don't know why they call it Spanish flu. I think it first happened in Spain. Probably the Spaniards were like, stop calling it Spanish flu. It had nothing to do with Spain. But I think that was the first case was found there. But yeah, we had a big flu, pretty similar to COVID, actually, except it wasn't COVID, it was the flu. But yep, spike went
what
away.
about the drop in 55?
Yeah, I don't know what that is. I feel like every time I show the graph, I'm like, I should look that up. I don't know. I don't know what that is. Is that like, I don't know. It's a good question. I see that also. Okay, but yeah, right. So that one I can't answer, but it is there on the graph, but it doesn't seem to mean anything in the grand scheme of things, right? Like it doesn't, if you go out a couple years later, whatever it is, kind of didn't have a lasting impact. Would you say that the world has gotten like crazy more dangerous? Way more people are dying. What's up with that?
I think that it's not necessarily getting more dangerous. I think because if you like compare our population in right now today compared to like 1900s,
Mhm.
I think there's going to be like a pretty big difference between the amount of people we have, and
Yeah.
if there's more people, I think like proportionally there's going to be like proportionally it might be like around the same or like a little bit better, but I think it's just because there's more people right now, the amount of injuries are gonna look bigger.
You're exactly right, Willie. So our population has absolutely exponentially increased. So this is now a graph that goes way back to the 1700s. And there were not a lot of people, not a lot of people, sort of increasing as our cleanliness and nutrition increased. And then right around, so here's 1900. And then where the other graph picked up, the first graph was 1980, which is like, actually, I don't really know, maybe around, 87 here. It is like astronomical. So this is sort of an important lesson, which you already really knew, is that if you're looking at counts over time, our population has absolutely exploded over time. And so since like, everyone does die, it's sort of like the end of the road. Seeing that more people are dying, but the population is growing this much actually makes me think that we're doing pretty good. Right? So and that was exactly the right thing to pick up on. Okay, so let's talk a little bit about life expectancy. Life expectancy is kind of a funny. Does anyone know what life expectancy means? It means something a little bit weird. It means, and let me see, I didn't even give myself a definition to read, so that was not a very nice gift to myself. It's the average amount of time that people will live given the year that they're born in, if the health conditions remain exactly the same. So the average amount of time that kids say who, let's pick sort of well, I mean, yeah, so we can see what happens here, but kids who are born today in 2025, how long on average do we think they will live, assuming that the disease stays exactly as it is right now in 2025? That we have this much heart disease, we have this much cancer, we have this much COVID. How long are they going to live for? And so it's a little bit ridiculous because we actually don't think the diseases are going to stay exactly the same as they are right now. But it gives you an indication of how well the country or the area is managing the diseases that they do have. And so here is a life expectancy chart over these different continental regions here over a really long period of time. And so I pulled this one back as far as the statistics go. And I did that, on purpose, so you could sort of see how dramatically things have changed. And so does anyone tell me what they see here? So this is age on the y-axis, how long on average. Average means half the people live more and half the people live less, right? It's the middle. And then this is time here on the x-axis. So what do folks see? Yeah,
I have
Alice.
a question. So like
Uh-huh.
around 1950,
Yeah.
like there's like a slight decrease in Asia and like
Mhm.
in the
Here you get
world.
this dip.
So I wonder if those are like coincidence or like if
No, probably
Asia at
not.
first.
Um, my guess would be that you're looking at a big event like a war or a famine or something happened that
I see.
caused a lot of strife. And so that kids who are born at that time, I mean, let's talk about the big picture. Well, we can talk about, so I mean, the big picture is that people really didn't live very long, all right, for a really long period of time. The average age is 30s or 40s. I would be an ancient grandma lady. So people were dying, and this is the average life expectancy. And so what actually a lot of this is driven by is very high infant mortality. So if a baby doesn't live, right, very long, then you have there's all of those zeros, they die before they're one, will really pull down an average. And so this is a combination of both life being very hard and people not living very long, and a lot of infant mortality that really drags it down. So it's sort of two things. And then sometime around the earliest part of last century, we see increases in life expectancy everywhere. Right? They're all going up, but they are not all going up equally. So Africa's definitely the worst life expectancy, and maybe Europe or Oceania has the highest life expectancy, and the range is a lot. And so we do see these dips. We can see, I mean, let me talk about this dip that we see here with COVID. And you see it everywhere because that's how pandemics work, right? It was everywhere. And so what this means is that a baby who was born in 2020 had a lower life expectancy than a baby who was born in 2019 or 2018, because a life expectancy is the average that the baby will live if the health conditions remain exactly as they are in that moment for the rest of their lives. And so COVID didn't stay as bad as it was in 2020, which is why the next year's it goes back up, right? And so when we see this dip, I can't tell you that I know what this dip is. It looks like it's reflected in the world, but it was driven by Asia. Something happened. There was a war, there was a famine, there was a crisis, there was a disease that was contained really sharply there, that babies who were born in that time would have reflected a very unhealthy situation that was happening that straightened itself out over time.
I think
So
it's
that's what
the
these
World
funny.
War II.
Well, World War II was 40 to 45. I
Mm.
think this was like, when was the
Vietnam
Vietnam
War?
War? That Vietnam War was like
Maybe
60.
like
It could have
Korea
been,
War.
Korean
Korea
War is
War.
1950.
Yeah,
I
and
think
I
it's the
don't know
Viet-
what part of Asia this is. My guess, there were a lot of
um
wars. So
I
my guess,
think
yeah.
it's both like Mao's Cultural Revolution, because there
Oh,
was also like a big famine back then, and also like the Vietnamese War together.
yeah. I mean, it looks like there was definitely a very, very stressful and deadly few years somewhere that drove that. So I don't know the answer, but they all happened around there. I mean, World War II would have been 40 to 45. So yeah, could have been that. So all right, so those are things to look at. We also look at life expectancy not just by region, but also by sex. And I think this must be sex assigned at birth. And we see, well, what do we see?
Female is the superior.
Women have a longer life expectancy. People who are assigned female at birth have a longer life expectancy than males. They both had this COVID dip, which will head off. And then yeah, does anyone know like some of the reasons why females have a longer life expectancy? I'm sort of jumping ahead in my lecture, but I'm wondering if anyone has like an idea.
Is it job related?
Probably not. The ones I'm thinking, maybe. I mean, in some ways it might be. Men usually have more dangerous jobs. Overall, in terms of like injury, they're more likely to be miners or firefighters or things that can have, yeah, but that's not the main ones that I was thinking of.
Does it have anything to do with like life habits developed over time, possibly?
Like life habits, like less smoking or something.
Yeah.
Yeah. Like that could be a big one. Women are less likely to smoke in general. Smoking is definitely will reduce your life. That's part of it. There's a couple of others.
Take a more risk like reckless driving.
Right. There are more unintentional injuries among males than females, and they happen young in life. So teenagers or young adults, and that will draw down your average, right? And then the other one is a little bit more subtle, which is that women do tend to live longer. Actually, estrogen is very protective against heart disease until menopause, when estrogen sort of goes away. So women do get as much heart disease as men, they just get it 10 years later. And so there's sort of, you add all of these things up together and you sort of get this, whatever this is, a 5-year on average increase in life expectancy. And you probably know this in your own lives if you think of the grandparents and aunts and uncles and stuff that you have in your life. Probably slightly more of the older ones are female, not all, right? But a few more of them. Okay. We also look at life expectancy by race, and I want to say a couple of things about how we classify race in the US. I recently was at a talk, and there was a colleague who's from India, and he's in America now. He's a really fabulous professor, and he got up and he said, before I moved to the US, I did not have a race. I had a caste, but I did not have a race. And now in the US, I have a race, but I no longer have a caste. And sort of the point, there's always some way to hierarchy people. Everyone has a way of binning, and that's exactly what these racial categories are. They were created by people who made the census as a way to classify people according to power and whatever. And these racial categories have changed over the years, and they've changed exactly related to structural racism and power. And there are groups that were considered one thing and not considered another thing, just depending on kind of the politics and power in the moment. And so these categories are not biologic. They're not inherent. They don't even exist in other countries, right? But they do, as we can see, have very real health effects. So we look at them because because they have very real health impacts. So if they have very real health impacts, but they're not biological or genetic, then what's causing these health impacts?
The communities, right? Because each community has like a different lifestyle culture.
So some of it could be cultural
yeah.
and lifestyle.
There's like the economic average because their what do you call it? Socioeconomic status is quite different for each one.
Yeah, and how did that come to be? I mean, I would argue that you're right, and I would argue that a lot of these structural, socioeconomic differences are due to systematic racism on the part of often the government in terms of you could think about the history of the Native Americans in the US, driven off their land and separated from their parents and put into horrific boarding schools and then put on reservations and then denied any funding. And it's going to take a lot of generations to pull back out of that kind of nonsense, right? And so there's more substance use, there's more mental health problems, there's more trauma. And this was absolutely socially and politically created. So when we see these differences, we are really, I think, looking at systemic racism and systemic issues. I will also say the differences within these groups are giant. And so I've had a handful of students now who have unpacked disease, particularly within the Asian category, and looked at folks with country of origin and how long they've been in the US. And you see wild differences, huge differences. Some people do way better than the average. Some groups do much worse than even the Native American groups. So the difference within these categories is really massive. So when we look at these, it's information, but it's not all the information.
I thought it's food intake because the whatever available or their traditional or socially what they eat, in terms of race, the Hispanic and Asian and Black, it's very different. So not only social economy or race and structured things, and food is a direct impact.
Yeah, and some of it is sort of regional and even regional from countries of origin, and some of it is dictated by what food is available. And we have in our country what we call food deserts, whole parts of the especially rural US where there's really not a lot of great food that's available. And so if the closest grocery store is a 7-Eleven, that you're going to eat differently than if the closest grocery store is like a nice market with produce and, stuff like that. And so, yeah, there's a lot of differences. There's food differences. Yeah. Okay. I want to look at causes of death across the US. So these are age adjusted. Someone else mentioned we have to consider the age distribution. So this is now, they've considered the age distribution, and we see that the annual death rate adjusted for age, so it's not just that older people live in these red areas, is pretty different. And so we can think about what are policies in place, what are access to healthcare, what are access to food, cultural issues, gun laws. There's a lot of things that can vary across the US and I mean, dangerous jobs, but it is definitely not equally safe to live in all states. I want to talk about the causes of death. So the 10 leading causes of death. And this is in 2021 and 2020 and 2021, just because I kind of wanted to show COVID and how COVID sort of has changed in there. But the leading cause of death in the US and almost everywhere is heart disease. That's what most people die from, followed by cancer. And then third now is COVID. I don't know if COVID will always be third. COVID didn't exist at all prior to 2020, and now it's third. And it is still third. We'll see where it goes. And then is unintentional injuries. And we're going to talk about injuries in a second. And the unintentional injuries is any injury that's not a homicide or a suicide. So if it's deemed a homicide or a suicide, then it's intentional. Everything else is unintentional. And we can talk about what the drivers of those are. And well, actually, we'll talk about what the drivers are now. Does anyone know what some leading causes of unintentional injuries are? So not homicide or suicide.
Car accidents.
Car crashes is a really big one. So second, there's one that's bigger.
Smoking.
Ooh, smoking is a good one. Smoking will cause cancer and heart disease, so it definitely will do injury, but it doesn't cause a death from it's not what they wouldn't cause it as I mean, unless you somehow lit yourself on fire with your cigarette or something, then it wouldn't lead to that.
Is it drug?
Yeah, it is. It's substance use. So that could be both prescribed or illicit. It doesn't really matter, but it's overdoses. And like 75% of those are opioids.
Does that
So-
include alcohol?
It does. It does include
Okay.
alcohol, though alcohol sometimes falls in its own category. So most of this is no, I think 75% of it. No, I think alcohol is its own category. It's a big category, but I don't think it's as big as car crashes, although it actually contributes to so many car crashes. I'm not entirely too sure. But this is mostly overdoses, and most of them are opioids. So this is fentanyl here, messing everything up. Stroke, and then chronic respiratory disease, Alzheimer's, etc. But these are the big ones. Okay, so I'm going to think a little bit about this chart. I'm going to fill in this chart, but I wanted to show it this way first. So we have the leading causes of death. We have heart disease, malignant neoplasms is that means cancer, COVID, unintentional injuries, and then we go down the list of everything else. But here on the top, we're going to look at the leading first, second, third, etc. cause of death by age category. So how old people are when they die. And so who dies from heart disease?
Old people.
Old people die from heart disease. Exactly. So if you look at the leading, we're more likely to die of heart disease than these folks, at least this year. Yeah. So if you look at the leading cause of death by age, yep, heart disease, leading cause of death among those 65 and older, cancer, leading cause of death among people who are younger, and then it's all unintentional injuries until you get to congenital anomalies, which are problems that babies are born with. They used to call them, they don't call them birth defects anymore. They call them congenital anomalies. Okay, so here we are looking at unintentional injuries. So this is the number one cause of death for most of the age groups up until 45. This is drownings, car crashes, drugs, right? So if you were, say you're working in a high school or a college and you're trying to keep people alive, That's what you want to worry about, right? You're doing drug education, you're doing driving education, you're doing mental health outreach so that people don't lean on these other substances to try to get themselves through, right? This is what will kill people when they're younger. And you also want them not to smoke, not because smoking is going to kill them then, but it's going to eventually lead to cancers and heart disease. So you're trying to build healthy habits. Yes, Daisy?
Is this all both sex
Mm-hmm.
and also that all races that I can see
Mhm.
clearly, all
Mhm.
races, it
Mhm.
doesn't matter all over the world?
This is only in the US.
Oh, okay.
Yeah, this is all sexes, all races, only in the US. The second leading cause of death, okay, well, now heart disease and cancer have switched among the older people because there has to be a first and a last. But here we get into the intentional injuries. This is suicide and homicide in our sort of middle-ish, 10 to 34-year-olds. And so here we're looking at, I mean, guns are huge because they're so effective at killing people. And yeah, so I don't have a lot of time to talk more about these things. We also get some cancers and other issues in babies and little kids. I'm not going to fill in the whole chart because that would get sort of old. You can see that this is a chart that was made by the injury portion of the government that deals with injuries, which is why the injuries are colored in there. But the point that I really wanted to make is different age groups, you have different issues, and you really want to sort of target in different ways, right? So that's sort of the main upshot I want to say. I also want to talk about one other way that we talk about disease and the importance of disease, and that's, or the impact that disease has on people's life. And that's with this DALY or DALY, this disability adjusted life year. And it's a little bit of a funny metric, but it ends up being pretty useful. And so it's a measure of overall disease burden, like how much burden the disease has on a population. And it's a combination of the years lost due to death and the years lost due to disability from a disease. And so the idea is that if you have a condition, let's say chronic back pain, chronic back pain might not kill somebody, right? But it might really impact their life tremendously. And really to sort of damage the quality of their life. Or something like Alzheimer's. Alzheimer's might eventually kill people. It does, but it can also, I don't know if you've known any folks in your life who have suffered from Alzheimer's, but it really dramatically reduces the quality of their life for years. And so if we just looked at death from Alzheimer's, we would see, well, people are kind of old when they die. And in fact, not that many people die from Alzheimer's, but that does not actually give you the right picture of the burden of disease that something like Alzheimer's has, right? It has a much larger disability burden, and it's pretty impactful. Like it almost they have these like totally intense charts for every single disease. There's a portion of the year lost due to disability. So if you die, the whole year is gone, right? But if you have something like Alzheimer's, they basically say that advanced Alzheimer's, most of the year is gone. The quality of that person's life has been reduced, not quite to death, but really close. If somebody has to use a cane, a little bit of the year is lost. Not a lot. You can still basically live your life. And so every disease has amount of disability, like how much of the year is lost due to disability, Willie?
I just want to know about like disability. Do you like things like mental like health issues like schizophrenia or or
Mhm.
like depression? Does that count as a disability or?
Yeah, absolutely, because it can affect the quality of your life. And so someone somewhere has made a calculation for how much of someone's life is sort of lost due to disability with something like depression. It's not going to be as bad as Alzheimer's, but it might be slightly more than a broken arm. And so I don't actually know how these calculations are made, but they do calculate it. So you'll see in a minute. It is a way to capture things exactly like depression, mental health, pain, things that people frequently don't die from, but have a big quality of impact on their life. So anyway, a DALY is a disability adjusted life year. and you'll see so now if we look at the burden of disease, this is worldwide in 2021, you can see that cardiovascular disease has the biggest burden. What epidemiology then does, and now we've had a big picture of epidemiology in terms of the distribution and of disease and the ways that we sort of measure disease in the population. And that's part of what epidemiologists do. But the other part of what epidemiologists do is they look at the determinants, so what causes these diseases, and that's the branch of epidemiology that I sort of spend the most time in. So in a human population, what exposures are contributing or protecting from these diseases? And so a few examples that I thought of, there's endless examples, are does air pollution increase heart disease? Does working night shift in your job increase the risk of breast cancer? But you can also look at protective factors. So did mask use cause less COVID? Right, so you could look at protective factors or causal factors. And the thing that ties environmental and occupational epidemiology together as a discipline is that we mostly focus on problems that can come from exposures. So the outside of this field, epidemiologists are either like heart disease epidemiologists or cancer epidemiologists or infectious disease epidemiologists, and they sort of concentrate on what the outcome is and all the things that can cause the outcome. Whereas people who are in my field actually look at the exposure side of things. So in environmental and occupational epidemiology, I think about what the environmental exposures are in health and what the workplace exposures are in health. And these are unique because these are often involuntary or ubiquitous, which means everyone has them. So we all have to breathe the air. And if you live in a city with air pollution, you're going to breathe air pollution, right? It's involuntary and it's ubiquitous. People who have jobs with a chemical exposure may not have any choice over where they work, or their other option may be so much worse that this is actually the best choice. And they usually don't have a lot of control over what they're exposed to at their job. So if you think about people who work in agriculture, it's going to be hot, right? They're farming in the heat and they're farming outdoors, and so that's involuntary because they have to. That's their job, and it's ubiquitous. It's hot. Everyone who's working out in the fields is going to be exposed to it. So these exposures, though, can be chemical, they can be physical, they can be biological, or they can really be about the workplace environment. Like I've studied shift work and heart disease and cancers. And so that's not chemical, physical, or biologic, but it's sort of work organization and aspects of work organization that people are exposed to. So I am going to stop here at this slide and pick up on Thursday. So this is what I suggest that if you want to read more, if you're a data person, go look at our World in Data. That is, you can you can just click around there, find something you're interested, figure out how that site works, dig into it a little bit. You can they make graphs. You can download the data from that graph if you're really a data nerd, and you can use a program that you like and recreate the graph. So that's one option if you like the data side of things. Otherwise, I suggest that you read the paper or wherever you get your news. I mean, read the paper and read something about a health condition. This could be mental health. This can be injury from war. I consider war a health condition. Something about how, I mean, there's unfortunately a lot to choose from. It could be a chronic disease, infectious disease. You could read something about COVID or whatever. You could read about the floods and natural disasters. What I want you to think about is who's the population that's been impacted or not impacted? Think about the power dynamics. You may have different opinions than I do about the power dynamics, but what are they? Are there any? And what are they? And then think about the causal and preventive factors and how close they were to the incident, right? And how did it take, I mean, to think about a flood, right? There's the flood, that was an immediate storm and it caused a flood. But you could go backstream and you could think about like, well, where are buildings built? And was there a warning system? And how did we get here in the first place? And I mean, floods happen. Floods have happened. I mean, I don't know, you read your history and read your Bibles, and like floods are a thing. So it's not like we created this out of nowhere. But that doesn't mean people have to, you know, who's living in the flood zones and who had warning and who didn't had warning and who listened to the warning and how are those warnings communicated, and just think about this from sort of like a systems perspective. Like if you wanted to prevent COVID, if you wanted to prevent a flood, if you wanted to prevent injury from a war, if you wanted to prevent heart disease, if you wanted to prevent depression or anxiety, if you want to protect transgender kids, you know, whatever it is that you want to read about, what are the power dynamics and where are the places that someone could intervene? The government could intervene. If you had all the money in the world, what would you intervene to do differently to help the people who are being impacted by the health, you know, the condition? And so that's what I would say. So either mess around with some data or think about our current state of affairs and sort of think critically about what's happening. And you're not going to know all the answers, but spend some time thinking critically about it.